everyone. Thank you all for joining. Today we have the great honor and privilege of having Dr. Mehta with us. Dr. Hiren Mehta is a practicing interventional pulmonologist at the University of Florida and involved in the Thoracic Oncology Group. He has board certifications in internal medicine, interventional pulmonary medicine, and critical care. His clinical work mainly involves patients with suspected or diagnosed lung cancer. His research has focused mainly on lung cancer screening and early diagnosis, developing prediction models for lung cancer in small pulmonary nodules, and on bronchoscopic intratumoral injection of chemotherapy for locoregional recurrence of lung cancer. His publications include original manuscripts on lung cancer diagnosis, staging, and original manuscripts on lung cancer treatment with intramural chemotherapy, as well as book chapters and review articles on lung cancer. During his time at the University of Florida, he has collaborated with several investigators, and through these collaborations, these collaborations have resulted in the development of extensive repository of tissues from patients with lung cancer and have additional relevant information. And he is currently collaborating with the National Lung Screening Trial investigators to develop methodologies to precisely stage lung cancer. He's also collaborating with several investigators to use Florida Data Repository to assess the penetration and appropriateness of lung cancer screening in the state of Florida. So Dr. Mehta, thank you so much for joining us today. We're so excited to have you with us.
Absolutely. Thank you for having me.
Wonderful. So to introduce myself and my team, my name is Priyanka Senthil, and with me I have Anish Gokilam, and we're part of the American Lung Cancer Screening Initiative, or ALCSI for short. And we'd like to take a few minutes to share about our organization and interest in lung cancer screening. ALCSI is a 501c3 nonprofit that works to raise awareness about lung cancer and lung cancer screening. We're a team of over 200 students and doctors located across the United States. And we do the work that we do because lung cancer is the deadliest cancer in the world, causing more deaths than breast, prostate, and colon cancers combined. Lung cancer causes about 380 deaths per day in the US alone. Lung cancer is very fatal because currently many patients are being diagnosed at a late stage when the cancer has grown and spread to other parts of the body. Lung cancer screening is an effective imaging technique that can be used to screen for lung cancer and has been shown to catch lung cancers early. However, less than 6% of people at high risk for lung cancer are currently getting screened. And the screening rate for lung cancer is much lower than the screening rates for breast, cervical, and colon cancers, which are about 70%. We believe that educating people about lung cancer and lung cancer screening is one of the most important and effective ways to increase the lung cancer screening rate for populations that would benefit from lung cancer screening. So far, we've given over 250 presentations on lung cancer and lung cancer screening to universities, hospitals, medical schools, and organizations around the US, as well as India, Canada, Brazil, and Mexico, reaching over 10,000 people. Over the last year, we've worked with over 340 mayors from every single US state to issue proclamations recognizing November as National Lung Cancer Awareness Month. And we've also had the opportunity to work with several leaders at the state level, including multiple mayors, Arizona State Senator Leila Alston, who is a lung cancer survivor, Pennsylvania Governor Tom Wolf, and Lieutenant Governor of Colorado, Diane Primavera, to issue public service announcements emphasizing the importance of lung cancer screening. In addition to our education, outreach, and advocacy efforts, we recently started this podcast series to share the personal side of lung cancer and provide a platform for lung cancer survivors as well as experts to share their stories. ALCSI also worked with US Congress members and senators to draft and advocate for the first ever House and Senate resolutions recognizing the importance of the early detection of lung cancer through screening. And in December 2022, the US Senate passed a bipartisan resolution for the third year in a row, designating November 2022 as National Lung Cancer Awareness Month and expressing support for the early detection and treatment of lung cancer. Senate Resolution 863 expands on previous resolutions by emphasizing the need for efforts to increase awareness of screening among veterans, women, and racial minorities. ALCSI also actively worked with Representative Brendan Boyle and Senator Tina Smith to draft and advocate for Catherine's Law for Lung Cancer Early Detection and Survival Act of 2021. Lastly, we want to end by talking a little bit about lung cancer screening. Lung cancer screening is done using a low-dose computed tomography scan. This scan uses low radiation doses, is pain-free, and takes less than 5 minutes to complete. The United States Preventive Services Task Force, also known as the USPSTF, sets guidelines for who should be screened for lung cancer. And right now, they recommend that people between the ages of 50 and 80 who have a 20-pack year smoking history or greater, and who are currently smoking or have quit in the past 15 years, get annual low-dose CT scans. 1 pack year is defined as smoking on average 1 pack a day for 1 year, and therefore 20 pack years can be met in a multitude of ways, including smoking 1 pack a day for 20 years or smoking 2 packs a day for 10 years, for example. If you know anyone who might be eligible for lung cancer screening based on the criteria we just discussed, Please encourage them to take our lung cancer screening eligibility survey so that they can learn whether they are eligible and have the opportunity to connect with our team at ALCSI to guide them through the screening process. And finally, we want to highlight there are other risk factors for lung cancer in addition to smoking, such as exposure to asbestos, a family history of lung cancer, COPD, and previous radiation therapy to the lungs. We believe it is important that we recognize these additional risk factors because a large number of people in the United States who have never smoked still get lung cancer. So thank you all for listening to that quick introduction to lung cancer and lung cancer screening. Without further ado, we can jump right into the podcast. We have a few questions prepared for Dr. Mehta, but we will also have a Q&A session at the end with questions from our live audience. So first off, Dr. Mehta, could you please introduce yourself and share your background?
Absolutely. I think you've done a lot of that, Priyanka, already, but I am a pulmonologist. Like I said, I'm board certified in interventional pulmonary, lung cancer, and pulmonary critical care and internal medicine. I've been doing lung cancer and lung nodule focused clinics for more than 10 years now. And my primary focus is to diagnose all the patients with lung cancer, stage them, and get them to the right treatment. And along with that comes lung cancer screening, identifying lung cancer early on. And so I do lead our disease-specific group for lung cancer and lung nodule at University of Florida. And I'm also primarily responsible for setting up the lung cancer screening program here at University of Florida and expanding it.
Wonderful. Thank you so much, Dr. Mehta. Could you talk a little bit more about your experience caring for lung cancer patients?
Yes. So I think it's something that can be put into many words, and it's something that is, we deal with this every single day. So like you said, a lot of patients with lung cancer are diagnosed. So 70% of patients with lung cancer are diagnosed at an advanced stage. By that, we mean they are stage 3 or stage 4. And what that really means for them is they usually are not candidates for surgery or definitive treatment, and they usually get what we call palliative treatment. And so certainly patients, it's hard to take care of those patients, because how do you look at them and tell them that, hey, you have advanced lung cancer and that it can be treated, but it cannot be cured. So that's one big aspect of lung cancers that we deal with on day-to-day basis. The second is that, as you know, a lot of these lung cancers are associated with smoking, and there is a few factors about lung cancer that patients and physicians or healthcare providers tend to have in the back of their mind. There is just an inherent bias towards patients with lung cancer. There is also the sense of guilt in patients with lung cancer, and the providers who take care of these patients have a sense of something like the patients themselves are to be blamed for that. And so a lot of these lung cancer patients unfortunately blame themselves for their lung cancer, and they get very demotivated. And that's one of the main reasons why lung cancer just doesn't get as much attention as breast cancer, just because there is a lot of nihilism, there is a lot of blaming, and there's a lot of bias towards lung cancer patients. But I really am passionate for lung cancer, and we do our best to take care of them, get them through the next steps. And really, the last 10 years have been exciting in the field of lung cancer when you talk about taking care of them, just because there has been lung cancer screening, which has come along. There has been a multitude of treatments, including expanding targeted therapies, immunotherapy. And so the last decade has been a decade of lung cancer, and we are very happy about it.
Yeah, that's wonderful. Thank you for sharing, Dr. Mehta. I think you brought up some really important points because there is, unfortunately, still a stigma around lung cancer. And as you had mentioned, a lot of patients have talked with us about how they felt guilt for their diagnosis, and especially with the association between lung cancer and smoking. A lot of individuals are surprised to hear that even individuals who don't smoke can get lung cancer, and because of that strong correlation between smoking and lung cancer, a lot of patients who might have smoked, and even patients who haven't smoked, they still feel that somehow potentially their diagnosis was brought on to themselves due to an action that they might have an action or their lifestyle choice. And I think that is very difficult for anyone, and especially when patients are diagnosed with lung cancer. It is a life-changing diagnosis, and when it comes with this sort of stigma and guilt, then it can make it very, very difficult to just get through that time. So I think that one thing that we're very focused on within our organization is just how do we overcome this stigma, and how do we educate people about lung cancer and lung cancer screening in a way that we can break down the existing stigma. And so I think we actually had a question about this later on, but I think it's a great time to talk about it here. Do you have any advice for other doctors, other healthcare professionals, or just community members on how we can start to break down the stigma around lung cancer, and really and make sure lung cancer patients and the community is supported and valued?
Yeah, I think you make a great point, Priyanka. Is I think we all need to get over the stigma and our inherent biases. And what I always think about it is, like, as more and more patients without smoking or who have been never smokers are found to have lung cancer. In fact, by some of the estimates, almost 30% of lung cancers are found in never smokers these days. Is that lung cancer, smoking is a risk factor, but we need to get beyond smoking, and we need to start thinking about what other risk factors are involved. And like I said, not all there are, like you showed, that there are a lot of other risk factors for lung cancer. And so we need to think beyond smoking, think beyond that stigma, and try to get rid of our inherent biases. And just think about, like, here, there's a patient who has lung cancer and who is looking for help. So how can we help the patient? And just think about the patient and the disease. And it's hard, but I always try to emphasize that they are just like any other cancer patients, and we need to take care.
Yeah, absolutely. And I think we just shared the USPSTF lung cancer screening criteria, the 2021 version of the criteria. And right now, lung cancer screening is recommended for individuals who have a heavy smoking history, and individuals who meet the requisite age criteria, which is between the ages of 50 and 80. And so, as you just mentioned, Dr. Mehta, there are a lot of other risk factors for lung cancer, like exposure to secondhand smoke, exposure to radon, asbestos, a family history of lung cancer, and other lung diseases like COPD that can increase an individual's risk for lung cancer. And right now, the USPSTF screening guidelines don't take into account these other risk factors. And so a lot of individuals who might have a lighter smoking history but are at risk for lung cancer due to the other risk factors are not being able to get screened at the moment. And this also ties into racial and gender disparities that we see, since racial minorities and women are more likely to have a lighter, packier smoking history when diagnosed with lung cancer, and also more likely to be diagnosed at younger ages. And so you do a lot of work on lung cancer risk prediction models. So could you talk about how, first, what lung cancer risk prediction models are, and how you think that lung cancer risk prediction models might help to overcome these disparities within lung cancer screening that we're seeing right now?
So what we're talking about is the risk prediction model for lung cancer. And like I said, the risk prediction models have been developed over the last several 20 or 30 years, and they do rely on a lot of things, including what's the age of the patient, what's the smoking history of the patient, how much they have smoked during their lifetime, where is the location of the nodule, where are the locations of the other nodules if patient may have had. Some risk models do rely on family history, some don't. So there is a lot of things that the risk models rely on. Unfortunately, what they don't rely on, or what they don't include, and it's never been studied, is the race of the patient, the sex of the patient, and things like that. And over years, what we have known is that females are more likely to have lung cancer at a younger age as compared to males. African American patients tend to have lung cancer at an earlier age as compared to the Caucasians, so on and so forth. And so it doesn't take into account for all that. And so when the lung cancer screening trial was published, initially the beginning age for lung cancer screening was 55. But when they realized of all these risk factors that were not accounted for, the United States Preventive Task Force did realize those, and so they did cut down the age to 50. And so right now, the current recommendation is to start screening at the age of 50, just to capture the younger patients, the minorities, women, and so on and so forth.
Dr. Mehta, what are some of the common risk prediction models that are being used now?
So one thing that I wanted to bring it to everybody's attention is that so there are two types of, so when you talk about risk models, that basically what you're telling is that somebody has a nodule on the lung and we don't know if it's malignant or not, and we need to figure it out. And so there are certain prediction models. The two most common ones that are used are the Mayo model, there is a Brock model, and then there's a VA model. Those are the three most common models that are used. However, there are two types of lung nodules that you have to understand. One is the one that was found on a routine CT scan, and the second is a nodule which is found on a screen-detected CT scan. And as of now, the Mayo model, the Brock model, or the VA model, none of them have been validated in the screen-detected nodules. And so we tend to extrapolate the same models for lung cancer screening scans and screen-detected. However, there is not a validated model for a screen-detected nodule as of yet.
And could you talk about the status of lung cancer screening in Florida?
So lung cancer screening, Florida is no exception when it comes to lung cancer screening as compared to the rest of the nation. Lung cancer screening is approved. CMS will pay for lung cancer screening. However, the penetration of lung cancer screening in Florida, just like anywhere else in the nation, is not great. Florida's rate for all the patients who are eligible for lung cancer screening, like you mentioned early on, less than 10% of patients who are eligible are actually getting screened.
And I know your work focuses a lot on how to precisely stage lung cancer. Can you talk about how lung cancer is currently staged and how pulmonary nodules are classified?
Yeah, absolutely. So, anytime you have to go through step by step when a patient comes to you with a lung nodule. And lung nodule is a precursor to lung cancer. All lung cancers present either with a nodule, which is a spot on the lung, which is less than 3 centimeters in size, or a mass on the lung, which is a spot on the lung, which is more than 3 centimeters in size. Anytime you have a patient who comes through, you initially risk stratify that nodule or a mass. You try to figure out what is the probability of the nodule or the mass on the lung being malignant. And there are three major categories we try to fit all these patients into. One is low risk, intermediate risk, or high risk. And it's not a very well-defined cutoff, and different people tend to have different cutoffs and what your thresholds are. But certainly if the likelihood of a nodule being malignant is less than 10 or 15%, then it's considered to be low risk. And usually we don't do any biopsies or any aggressive management for those patients, and we tend to follow them. Anything that's more than 60 or 70% is considered to be high risk, and those are the patients that need biopsies and subsequent management. And then the intermediate risk group is the one which is the most challenging, which falls between the 10 and the 60 or 10 and 70%, where you really have a frank conversation with the patients and say, hey, these are the options and what do you want to do? And so initially, once you get past that, and once you determine that the nodule is moderate to high risk and it needs further workup, then you go on to the next step, which is how are you going to make a diagnosis? And certainly the diagnosis is based on a biopsy. And you try to figure out what the best way to biopsy that nodule or the mass on the lung is. Either it's going to be from the mouth going through the bronchial tubes into the lungs and taking a piece of it, which is called a bronchoscopy, or it's going to be using a needle which goes through the chest wall, through the lung into the nodule, which is called a transthoracic. Once you make a diagnosis, then you talk about staging of cancer. And the reason why staging is important is because that influences the treatment outcomes. And there are, as like any other solid organ cancer, lung cancer has 4 stages, 1, 2, 3, and 4, where 1 is the least advanced and 4 is the most advanced. And to pursue further staging workup, you need a few more scans. One of them includes a positron emission tomography. That's just a fancy name, but it basically, in common language, is a whole body scan, which looks for if the cancer or the nodule has metastasized. The second thing you always have to do is, just like with people who are in the medical field or who have been through this, like for breast cancer, there are all the cancers have a certain pattern of drainage in our body, and the cancers usually drain first into the lymph nodes. What it really means is all the cancer cells, they start out somewhere at a particular place in the lung, and then they kind of go through the path of least resistance, which is the drainage system, and into the lymph glands, which are the glands which we have everywhere in the body, including the lungs. And so you need to biopsy them to make sure there is no spread to the lymph nodes. And once you have a diagnosis and once you have the stage, then you talk about the treatment options for the patient.
So, Dr. Mehta, just switching gears here, but we recently did a podcast with Dr. Wade Imes, who's done a lot of work on biomarkers for lung cancer. For those who may not be familiar, biomarkers are simply biological molecules produced by the body or the tumor in a person with cancer. So these biomarkers, which can be blood-based or genomic, for example, can help to improve risk stratification after nodule detection and also provide information for appropriate targeted therapies. So Dr. Mehta, how do you see risk prediction models working alongside biomarkers?
So that's really a great question, and that's really where the field is headed. There are, like you said, there are different types of biomarkers, and I'm not going to focus on the biomarkers that you mentioned about, which is used for targeted therapy. So that's once somebody has already been diagnosed with lung cancer and you're trying to figure out the best therapeutic option, and you do blood-based biomarker for them to figure out whether they're candidates for targeted therapy, which is a separate topic in itself. But if you go to pre-diagnosis biomarker, which is what I suppose our focus is when somebody, we talked about the risk prediction models, somebody has a spot on the lung, you're trying to figure out whether it's malignant or not, and the surest way to do it is biopsy. But short of a biopsy, we talked about using the nodule characteristics on the scan, we talked about the location, the size, we talked about patient factors, including age, and we talked about their smoking history. There is the whole field of proteomics, which is biomarker-based studies. And there are two types of biomarkers. One is blood-based or serum-based biomarkers, and one is biomarkers that you collect from the patient's mucosa, which is when you're doing a bronchoscopy, you collect specimen and you collect biomarkers. If we talk about serum-based biomarkers, to date, unfortunately, I mean, it's a great field. There's a lot of studies going on, but there are no approved, FDA-approved serum-based biomarkers which can be used for detection of lung cancer. But it's a field which is in progress, and I'm pretty sure in the next few years, it's going to be ready for prime time, and it's going to be something that's going to be available commercially, and we will be incorporating that in our risk prediction models. The bronchoscopic biomarkers, which is when you actually, when you're doing a bronchoscopy, that means you're going in with a camera from the mouth into the bronchial tube, and you're attempting to biopsy the nodule and the lymph nodes. What you do is you collect a specimen from the bronchial tube, just a sample of their mucosa. So then I was talking about the bronchoscopy-based biomarkers, and the concept is field of injury, that if the smoking which caused injury and caused nodule to be malignant, that same genomic changes would be detected in the proximal bronchial tubes. And there are biomarkers which are commercially available for that. They have never been incorporated in any of the risk models, but they are used in addition to the risk models that we have. So, you know, long story short is that biomarker is an evolving field for detection of lung cancer. A lot of them are not ready for prime time, but there's a lot of research going on for those.
Yeah, it's very exciting to see how potentially the new research and new developments that is happening on the biomarker side can also be integrated with the research that's being done on the lung cancer risk prediction models, and how we can potentially combine the use of biomarkers and risk prediction models to improve early diagnosis for lung cancer. patients. And of course, biomarkers can also be used to inform treatment and prognosis as well. But it's just very exciting to see how potentially in the future, um, the way we stratify risk for lung cancer might be less on the criteria currently used by the USPSTF guidelines, but more so the risk prediction models in combination with the biomarker. So that is very exciting. And along those lines of, in terms of like new areas of research, we wanted to ask, do you see a role of deep learning or machine learning in staging lung cancer?
Yeah, so I mean, I think what you're probably getting at is machine learning or artificial intelligence, not only staging, but actually diagnosing lung cancer as well. And again, like I talked about proteomics, which is an evolving field of biomarkers, we like to call it radiomics, which is the machine learning field. And what it really means is there are patterns, right? So computers, as we know, are very good at identifying patterns. And we talked about that there are nodules which can predict cancer based on how they look and based on the pattern of their location, size, speculation. Those are all radiographic characteristics, and a machine should be able to pick up those patterns and generate a number or a risk model which kind of predicts whether this is malignant or less likely to be malignant, high risk to be malignant, things like that. And currently, we are already doing that. It's just that the machines are not doing it. We are doing it. And we think that computer-based algorithms probably are smarter than what human eyes can miss, and they can predict it more appropriately. Again, there is a lot of research going on in the field. There are a lot of articles being published, and different people have looked into, again, it's important to differentiate screen detected nodules versus non-screen detected, and people have published on it. And people have looked into volumetrics. In fact, one of the big lung cancer screening trial, the Nelson trial, which was published a couple of years before, in 2018, looked at the volumetric analysis of the lung nodule, like to calculate the volume of a nodule rather than just calculating the diameter and come up with a risk prediction model. So all that, again, is very exciting. It's actively being looked at, and I'm pretty convinced, just like biomarkers, this is going to be part of our risk prediction model incorporated into the algorithm over the next several years.
This is all really interesting stuff, Dr. Mehta. Could you explain to our audience what exactly bronchoscopic intratumoral injection of chemotherapy is?
Absolutely. So again, that's something that what it really means is, in simple terms, and I'll give you the rationale once I tell you what it involves. What we are doing is we are going in with our camera, the bronchoscope, the endoscope. We are going into the lung, we are finding where the tumor is, and we are injecting the chemotherapy drug directly into the tumor. And so that's the technique in short. The rationale for this technique is, like lung cancer chemotherapy, like any other chemotherapy, is administered through an IV. It's administered systematically. What it really means is the drug goes into your system, it goes to the cancer cells and it kills the cancer cells, but at the same time, it goes to a lot of normal cells. And so that's why all of you, I'm sure, have known or seen someone getting chemotherapy and dealing with the side effects. And so what it tends to do, it tends to kill a lot of normal tissue, which accounts for all the side effects from hair loss all the way down to infections and things like that. And so what we are trying to focus on is there a way that we can go in directly to the tumor and inject chemotherapy directly into the tumor cells? In that way, the cancer cells get the most concentration of the chemotherapy, highest concentration, yet there is very little spillage into the systemic circulation, and that leads to minimal side effect. And so that's what our area of research is to try to target the cancer cells wherever we see them directly without causing systemic side effects.
Awesome. And so you talked a lot about the pros of bronchoscopic intratumoral injection. Can you talk about some of the cons?
Yeah, absolutely. So again, one of the biggest con is what is the advantage of it turns out to be a disadvantage too, right? So you try to go in and you inject just a cancer cells directly. However, there is a very well-known mechanism of cancer spread is that the cancer cells get into the bloodstream and then they spread, and that's how cancer metastasizes. And so this method can actually go and treat the tumor itself, but it doesn't do anything to prevent a spread or the cancer cells which are already in the circulation, which haven't seeded into other areas of the body yet. It doesn't do anything to prevent them from seeding. So that's one of the major side effects. The second side effect really is it's an invasive procedure. So every few weeks when we go in and inject, patients have to go under anesthesia. They have to get a procedure, go in, and have a procedure done. Which a lot of these patients have a lot of comorbidity, patient population, and it's a high risk for them every time you get them under anesthesia and try to do a procedure. So I just see them those two as major side effects of the procedure, or the con of the procedure. I shouldn't say side effect, the con of the procedure.
What do you see for the future of early detection of lung cancer as far as new models or techniques?
So there is a lot of so lung cancer screening trial changed how we think about lung cancer. It's the only screening study which targets risk populations. So if you think about your colon cancer, breast cancer, think about your mammograms, colonoscopies, they just have a age cutoff. So hey, if you're 45 or more, you start getting this annual basis, but they don't have risk-based models of prediction, prostate cancer, etc. Whereas lung cancer screening is a risk-based cancer screening. So it's already a step ahead of all the cancer screenings. You're targeting the highest risk population. I think as we get into future, we're going to start learning more and more about which patient population to target. Currently, like you mentioned, the age and the smoking history, we tend to focus on those things. But I think as we learn more about lung cancer screening, we're going to start learning about, hey, if you have a family history, maybe you should do this. If you have history of COPD, maybe you're at higher risk and maybe you should do this. So I think one is that we're going to identify more risks, and the lung cancer, it's going to be a wider net that we're going to cast in future to identify patients with early stage lung cancer and get lung cancer screening. So that's one of the things that I see coming in future is trying to have risk-based, it's already a risk-based screening tool, but have it more risk stratified. Second, I think is we are going to start learning about biomarkers and how that can be incorporated into early detection of lung cancer. Lung cancer not only doesn't have a biomarker, serum biomarker currently, but it also doesn't have a biomarker to evaluate for treatment response. So like you probably know, as prostate cancer, there are biomarkers to evaluate treatment response. And you just get a blood draw and you say, hey, yeah, your cancer is responding or your cancer is not responding. Lung cancer doesn't have that. And so I think we are going to find biomarkers in future which are going to help us detect it early, but also monitor treatment responses. And then I think as our CT scans and our PET scans and our radiology techniques keep evolving, we're going to find cancers at a sooner and sooner stage, and we're going to get better at predicting malignancy based on the volume, the location, the borders, and I think AI and computer generated algorithms are going to be incorporated more and more into our risk prediction tools.
Yeah, absolutely. You brought up some really great points in terms of how we can better stratify risk for lung cancer among different patient populations. And so I definitely think that improving how we stratify risk for lung cancer is one of the major battles. But the other major battle, I think, is definitely how do we increase the utilization of lung cancer screening? And so at the beginning of the podcast, we talked about how nationally, less than 6% of individuals are currently getting screened for lung cancer. And these are individuals who are at high risk. So not the general population, but of high risk individuals, less than 6% are getting screened. And in Florida, you had mentioned that less than 10% are getting screened. And so in your opinion, how can we best increase the utilization of lung cancer screening in Florida and around the US?
So that's really a great question. I think to answer that question, we really need to figure out why, right? So why is it so low? And if you were to ask that question of why is it so low, I think some of the same things that actually makes lung cancer screening that effective, that risk-based screening, is actually also the one which makes it harder for us to get to the patients. And just to give you some example, like you pick up patients who have more than 30 years smoked, who are more than 50, 60, 70 years of age, you're already selecting out um, patients who are educationally, socioeconomically on the lower end of the strata in the society. And so that's one of the main reasons that the patient who actually benefit the most from lung cancer screening are the ones who least get it, because the more you have the smoking risk, the more you have other risk factors, the more likely that you are going to be on the lower end of the socioeconomic strata, and so you are not going to get the healthcare. So that's one reason why lung cancer screening doesn't have that good of a penetration. The second is, we talked about the stigma of lung cancer screening. Lung cancer is the only cancer which comes on with the stigma that no other cancer does: prostate, colon, breast, none. And that creates implicit biases, not only for the not only from patient themselves, but their family members and healthcare providers. Um, Lung cancer just doesn't get that kind of attention because people and providers blame it on the patient. And so one is the socioeconomic status, one is the implicit biases and stigma. And then the third is that a lot of attention has been given to the lung cancer screening and how it increases the rate of unnecessary procedures and unnecessary biopsies and unnecessary complications, which no other cancer has gotten that kind of an attention. In fact, colon cancer screening is an invasive procedure. Like, I mean, forget about getting an invasive procedure after the fact. You start out with an invasive procedure when you're going to get a colon cancer screening. But for some reason, lung cancer screening, a lot of attention has been paid to the adverse events and the side effects and the invasive procedures, which actually are less than 2% of patients who actually get lung cancer screening. And then I think lung cancer screening is also the new kid on the block when it comes to cancer screening. And people have been burnt by previous cancer screenings, including breast cancer, prostate cancer, where over the years we have learned that we tend to find a lot more cancers which are never going to be significant ever, or what we call an overdiagnosed cancer. So I think these are the four major reasons why there is not good penetration of lung cancer screening. So to improve penetration, you have to target all of that, right? We have to not have those biases, try to take the stigma away from lung cancer diagnosis, try to educate our patients, especially, and it's hard, especially on the lower end of the socioeconomic status, to get involved in healthcare, in their own healthcare. And then try to educate the providers on, again, avoiding stigma, educate them on the benefit. Lung cancer screening you probably have to screen 300 lung cancer screenings to prevent one lung cancer related death, as compared to doing 1,000 colonoscopies to prevent one colon cancer related death. So you have to educate the providers that, hey, this works. It's something that works, and we should offer it to our patients. So I think it's unfortunately a multi-level problem which needs a multi-pronged approach at the level of patients, at the level of society, and at the level of healthcare system.
Yeah, that was very well said, Dr. Mehta. We completely agree with all those points that you brought up. We've talked with a lot of patients that said that they were, initially worried about getting screened because maybe that they did have a smoking history, and if they did find something on the scan, then that is very scary and makes things very real. And so patients have told us that they've had a hesitancy to get screened because of the fear of like the guilt and all the stigma that might come with a diagnosis. So I definitely agree that overcoming and breaking down that stigma is so important. And also, like you mentioned, making sure that we educate the public about lung cancer screening. And a lot of people haven't even heard about screening, and those who have heard about lung cancer screening don't know the exact criteria, and that knowing that criteria is really important in knowing whether you're eligible or not at the moment. And not just with the public, but even healthcare providers, general healthcare providers, and primary care physicians. Studies have shown that not all primary care providers and healthcare providers are aware of the screening guidelines as well, and especially that they've been updated in recent years. And so I think just increasing awareness and education among just the general public and among healthcare providers is key as well, because a lot of patients do trust their doctors, and right now a lot of patients are having to go to their doctors and ask them if they're eligible for screening, whereas it should be the other way around, where patients the burden shouldn't be on the patients to ask their doctors if they're eligible or not, but patients should be receiving this information during the regular checkups, just like they do with other cancer screening. So definitely agree with everything that you had said. And I think you brought up a really good point about how within lung cancer screening, there's been a lot of focus on the potential risks that comes with lung cancer screening, such as radiation and maybe potentially invasive follow-up testing that might come with a inconclusive scan. And with lung cancer, for example, the Centers for Medicare and Medicaid Services, they require a shared decision-making visit before a patient can actually receive a CT scan. And now there's, in February of this year, there recently were some changes that make the restriction, the guidelines a little bit more lenient, but patients still have to go in and have a separate meeting with their provider that goes over the risks and benefits of lung cancer screening. And in that, under those shared decision-making guidelines, there's a requirement to discuss radiation exposure for lung cancer screening, and when that requirement is not there for other cancers, such as colon cancer, which has screening exam that exposes patients to higher levels of radiation. So I definitely think that I definitely agree with what you had said. And there's a lot of different layers to potentially why the uptake of lung cancer screening has been lower, but addressing the stigma, increasing awareness and education among the public, and educating people about the risks, but also the benefits. And I think all three of those approaches can also go a long way. So, yeah. Wonderful. Well, I think we can now transition into our audience Q&A session. And so we have a couple of questions that have been submitted to us that we'll start off with. But if anyone in our live audience has a question, feel free to submit it in the chat or just unmute and ask. So our first question that we have is, what do you consider to be the most challenging and rewarding aspects of your work?
So that's a great question. And I think the answer is in everything that we talked about. The most challenging is really to try to identify these patients, try to pick them up early on in their disease and try to cure them, try to get rid of the lung cancer. What is frustrating is we know that we could find lung cancer at an early stage. It doesn't have to be only 20 or 30%. We can, once we find them at an early stage, we can cure them. We can give them 80 to 90% progression-free or cancer-free survival at 5 years, which is as good as any other cancer. So we know who these patients are. We know how to get them better. But again, it's challenging and frustrating that to date still see more patients who are diagnosed with stage 4 lung cancer than who are diagnosed with stage 1 lung cancer. So that's really challenging. What's really satisfying is, like I said, the last decade has been a decade of lung cancer. If you look at all solid organ cancers, there has been not as much innovation in any other cancer as compared to lung cancer in the last 10 years. And that includes lung cancer one getting all the attention, right? So groups like yours, which have come up, and there are several similar groups, there are several advocacy groups, which now have moved on from breast cancer and have started focusing on lung cancer. So there is growing awareness among lung cancer. Lung cancer screening has come on in the last 10 years, advanced targeted therapies, biomarker testing, immunotherapy. There has been more innovation and publications and research in lung cancer than any other solid cancer in the last 10 years, which is very exciting to be able to offer our lung cancer not the same chemotherapy which we've been offering them since 1970s and 80s, but to tell them that, hey, there are new things and which actually make a difference.
Wonderful. Thank you, Dr. Mehta. We have a question from Mahima. So Mahima, if you want to unmute and ask your question.
Dr. Mehta, I really loved your presentation today and your insights on lung cancer screening and education. I'm actually from Chicago, but live in South Florida for college. And I'm just curious to know, considering that Florida has a large Hispanic and African American population, especially here in South Florida near Fort Lauderdale, specifically Broward County, a lot of individuals in this community have challenges with their nutrition, with their socioeconomic status, and community-based health centers are very impactful for these communities because they're able to access care to a certain extent, even if they don't have health insurance. So I'm just curious to know if you could elaborate on the work that you do at UF, and perhaps we can bring some of that awareness and education about lung cancer screening in collaboration with ALCSI to these community-based health centers so that this important yet vulnerable population can be educated about lung cancer screening and proactively be screened before cancer progresses.
Yeah, absolutely. So that's a very good point, and we know that these are at-risk patients who are getting the least, who are not getting the care that they deserve, especially from lung cancer screening standpoint. And I will tell you that at UF, us being we are the flagship hospital for the state, and so we do have a lot of uninsured, underinsured, and patients from minority, from a lot of minority patient population. And I think what the key is there again, one, it's important to have access, right? So if you have limited access, then only the ones who have the highest means are going to get it. So one thing is to improve access, and by that I mean have, like you said, have more community-based clinics, have more outreach, show them that you are there, you are available, and this is what you have to offer. And what we have done from that standpoint is we have had like designated lung cancer screening clinics where all that we do is see patients who need lung cancer screening, the risk benefit discussion, and so we have improved our access. That's one of the most important things. The second is try to educate them. So we have done several outreach. We have tried to reach out to the poorest parts of the county and try to tell them that, hey, this is out there, this is what saves life, and you need to enroll if possible. So one is to have access. Second is to have them feel welcoming. A lot of times minorities feel unwelcomed and they feel like they are being they're marginalized. So try to avoid that, and then try to educate as much as possible. So we have been trying to do it on all different levels. In fact, there are certain things that we are looking forward to, including trying to have an outreach just like mammogram does, where you have a, a bus, really, in most simple terms, where you take it to the neighborhoods and say that, hey, we are going to do lung cancer screening, or we're going to do breast cancer screening. So we are actually looking to maybe have a truck where we can actually do lung cancer screening in a truck, reach to the patients rather than patients coming to us.
Thank you so much.
So Dr. Mehta, what are some promising projects in research in the lung cancer field that you've heard of that particularly interest you?
Oh, it's like we can talk about this for a long time. So we talked about a lot of focus on early diagnosis of lung cancer, and we talked about the biomarkers, and we talked about the radiological early detection algorithms and models. If we talk about the treatment standpoint, there is a lot of work which is going on in the field of lung cancer and oncology, including identifying patients early on immunotherapy has been a game changer for lung cancer. There's a lot of work going on, try to move immune therapy from the most advanced lung cancer stages to early on in cancer, including stage 1, stage 2, try to give them immune therapy before they get their surgery or before they get their radiation. There's a lot of work going on trying to use immune therapy in addition to radiation or along with radiation. And then the whole spectrum of biomarker testing and targeted therapy for lung cancer, including, to give you an example, like 15 years ago, only 10% of lung cancer patients could be treated with targeted therapy. And that number has expanded to almost 20 to 25% in the last 10 years. Not only that, but there was only 2 biomarkers that we could target 10 years ago. And now there is at least 8 biomarkers that we can target. And so there is tremendous amount of work going on in the field of lung cancer. And like I said, that's something that keeps me excited and keeps me very optimistic and keeps me going.
Wonderful. Yeah, I think you brought up a lot of great points, Dr. Mehta. And going back to your mention of the mobile screening vans, I think that is also a very exciting new avenue for lung cancer. I believe the CHI Memorial Hospital's Breathe Easy mobile lung CT van provides them low-dose CT lung screening in their communities, and they've had a really great experience with their van so far. And there's also been another mobile screening van that they parked in the parking lot of a shopping mall and found great uptake there as well. So I think that is if we're able to pull those off, especially in more rural locations, that could be a great way for us to also target and reach patient populations that might not be able to come to a screening center or a hospital. So definitely agree with that. Our next question that we received is, what are your research goals and plans in the next 5 years?
So my particular focus is, like we initially mentioned, is that my particular focus is early diagnosis and staging and intratumoral chemotherapy. So what I'm really working on is to try to have bronchoscopic treatments of lung cancer. And so we are exploring, so we have injected chemotherapies in lung cancer. Like I said, immune therapy has really taken off in lung cancer treatment. And so we are looking at models on injecting immune therapy directly into lung cancer bronchoscopically and see if we can get a better efficacy as compared to systemic immune therapy. That's one thing that we've been working on, and we are going to focus over the next 5 years. A few other things that we are focusing on heavily, we are a part of a lot of biomarker studies. And so that's something, like I said, is going to come on in the near future. And that's something that we are actually enrolling our patients from the clinic right now. And then we are also looking at ways to treat lung cancer bronchoscopically, if that means doing microwave ablation of the lung tumor or doing like photodynamic therapy. So those are all localized means of destroying lung cancer, minimally invasive ways. And so those really are the 3 things that we are focusing on right now.
What does your day-to-day work life look like?
So, as I mentioned, that lung cancer is my focus, and that's my clinical expertise and area of interest. But at the same time, I also am a board-certified pulmonologist and a critical care physician. So we do different things. I do ICUs, so I take care of critically ill patients in the intensive care unit when I'm on the ICU rotations. And we have been certainly very busy with COVID, so we do that. I do see on Thursdays is my lung cancer clinic day. And what that means is that all day, on an average, I see around 30 to 40 patients who have lung nodules or spots on their lungs, which are suspicious for cancer. So that's my lung nodule clinic that I do every Thursday. And then the rest of the days, I'm doing bronchoscopies, biopsying this lung nodules, cancer. We are treating, we are staging them. And we also are putting a list together, presenting them at our thoracic tumor board, and trying to get them the best treatment options.
Hi, I had another question. So you spoke a lot about stigma, which I think is very important in lung cancer and to get people to get screened, but especially stigma amongst providers and medical professionals. So how do you think the best way to dismantle stigma amongst providers is?
I mean, I'll be honest with you, there is no easy answer. Education is probably the only thing that works. What I try to do is anytime I see somebody with lung cancer, I try to tell them that yes, smoking is associated with lung cancer, but 30% of lung cancer happens in never smokers. So it is a disease which, and in fact, I don't know if I brought up the statistics, but if you consider lung cancer in never smokers as a separate entity in itself, then that's the 6th largest cancer in the United States. So lung cancer in never smokers itself is a big number. And so that's one way to educate that is that it does happen in never smokers. So it's not the right thing to blame it on the patient. Lung cancer happens regardless of whether you're smoked or not. Second is education. We just need to bring it to everybody's attention, keep repeating that lung cancer screening saves life. Yes, all of us have made mistakes in the past and all of us have done something that we are not very proud of. But here we have a patient, here we have an opportunity to offer them a test which can potentially save their life. And so really what it comes down to is education, and the more we talk about it, the more it percolates. And so I think keep talking about it, keep educating, keep telling that lung cancer screening saves life. And one of the ways I do is I go to grand rounds or at meetings for our family practice physicians, our internal medicine doctors, who are usually the primary care doctors who are first point of contact with the patient. And I talk about lung cancer screening. I go every year, and I talk about it to them and try to bring it on their attention that yes, it may be something that patient may have done to themselves, but that's past. Why don't we offer, here's a patient in front of them, why don't we offer them the best standard of care that's out there?
So I think we're going to go ahead and conclude the podcast. Again, thank you so much, Dr. Mehta, for your willingness to share your wealth of knowledge and perspective on many of the pressing issues in the lung cancer world. We truly appreciate all the work and research that you are doing. And thank you everyone for listening to our podcast. Please keep an eye out for our upcoming podcasts and events, which will be listed on our website, www.alci.org. This week, we have podcasts with Dr. Madhuri Rao, Dr. Esalamari Rodriguez, and lung cancer survivor Ashley Rickles. Zoom registration and information on these individuals can be found on our website under calendar events or our Instagram bio. Thank you and have a great day, everyone.
Thank you.
Thank you so much, Dr. Mehta. Thank you, everyone.
Thank you all.